Welcome all of you to the next session of the neonatal hypoglycemia, which is part of the nurses module training. Introducing myself, I am Dr. Sundar Singh. I'm currently working as Associate Professor of Pediatrics and Unit Charge of Neonatology at Dr. Somerville Memorial Medical College, Karakonam in Trivandrum in Kerala. First of all, I thank the Lord Almighty for giving me this opportunity. And I thank all the office bearers of NNF Pathanamthitta and NNF Kerala and all others who have invited me for this to be part of this great nursing module. So since the last nearly 2.5 months, all of you are already into neonatology, different topics, starting from small topics, big topics by eminent neonatologists of the country. And now we are into an important topic, that is neonatal hypoglycemia. These 3 days we have been we are planning to discuss. Yesterday we have had the discussion on the basics, the causes of neonatal hypoglycemia, also the various etiological factors, also glucometers, how they work, and and all the problems associated with that. It's already been discussed. And today we'll be moving on to certain aspects of hypoglycemia, which is quite important, and all of you should be very well knowing. First, we'll be discussing the symptoms and signs of hypoglycemia. Next, the complications, immediate as well as long-term complications of hypoglycemia. Then we'll discuss the risk factors of hypoglycemia and the guidelines for monitoring blood sugars. Then lastly, we'll be dealing with the nursing errors. So we are moving on to the topic. First, looking on to the symptoms of hypoglycemia. Hypoglycemia is a medical emergency. It's in neonates, and they may manifest in various ways. Some may just manifest as just a lethargy or an apathy. Some may manifest as poor feeding. Baby was feeding quite well, and the last few hours or few minutes, baby is not active or not feeding well. This may be just their complaint. Sometimes baby may be just feeling cold. There will be some tremulousness of the limbs. Some babies, especially preterms, there may be some cessation of breathing, which is otherwise called apnea, which will be coming to that. And we should be also aware that many of the cases of hypoglycemia are asymptomatic. They may not manifest any symptoms. They may not manifest most of the autonomic signs of hypoglycemia, which is seen in adults, and they may remain asymptomatic, which should be picked up on time. Next, we are going to the signs of hypoglycemia. So, what are the signs that we should that is seen in hypoglycemia? It may manifest as hypotonia. Hypoglycemia may manifest as seizures or jitteriness, that is overactivity. As I mentioned in the last slide, it may manifest as apnea, especially in preterm babies. And hypothermia is one of the manifestations. They may just manifest as cyanosis, as you can see in the picture. Cyanosis may be a manifestation of hypoglycemia, and also congestive cardiac failure can be a manifestation. So hypoglycemia, though we say it is just a decrease in the blood glucose, it can manifest in a lot of ways, with varied signs and symptoms, which can mimic many other neonatal conditions as well. And also, as I mentioned already, it may, in various situations, it may be just be asymptomatic. Next, we'll move on to the complications of hypoglycemia. Hypoglycemia, though it is looked down upon as a minor complaint or a minor issue, we should be aware that hypoglycemia is a notorious thing which can result in long-standing problems to the patient. Very often, the babies who are having hypoglycemia are seen to have delay in motor as well as language development. Their developmental scales may be low, and they are highly prone to have ADHD, that is attention deficit hyperactivity disorders. They may be found to have a low IQ when compared to others. They may be presenting with motor deficits and microcephaly, that is smaller head circumference. They may manifest as abnormalities in hearing, with this, which is evident in brainstem evoked response audiometry, and it may be even manifesting as remote symptomatic infantile onset epilepsy, which is one of the manifestations of seizures. And from this much, you would have understood that hypoglycemia is not something which is just benign or just to be looked down upon. It is something which is able to cause long-standing problems in the baby. And I want all of you to be also aware that even a single episode of moderate hypoglycemia, when studies have shown that can result in long-standing neurodevelopmental deficits. And the more the duration of hypoglycemia and the less is the blood sugar, the more is the chance for risk. At the same time, we should be aware that even a single episode can result in long-standing defects. So it is not something to be looked down upon. It is something which has to be given utmost importance. I hope all of you know this, but I am just reiterating that you should never miss a case of hypoglycemia in any way. Now let's look on to the pathology. What happens to the brain? What happens to the body in hypoglycemia? We know the biochemical aspects, that when the sugar is low, what happens to the different pathways in the body. The automatically or glycogenolysis sets in, and also how mechanisms of maintaining normal glucose homeostasis sets in. I'm not going into the biochemical aspects, but what are the pathological problems happening in the brain? The typical injury in hypoglycemia is in the right occipital cortex and also in the subcortical white matter. In acute hypoglycemia, we may see neuronal injury in the cerebral cortex, especially in the occipital and the parietal cortex. Also the hippocampus, basal ganglia, brainstem, and spinal cord. You may also see glial degeneration, and few cases of periventricular leukomalacia are also found in case of hypoglycemia. What about chronic changes? Microcephaly, I already mentioned that microcephaly can happen due to hypoglycemia, and loss of cortical neurons, calcifications in these necrotic areas which were seen, and the sparing of cerebellum is typically seen in hypoglycemia. There are a lot of MRI changes associated. You can see the picture, and I want all of you to be very clear in understanding the pathology. Though you don't have to be very thorough with the pathology, but you need to be clear about the long-standing problems and how that we should not miss. Even a single episode, I already mentioned, I'm still reiterating, that can cause many of these changes. Now let us look into the risk factors of hypoglycemia. We have already discussed what are the causes of hypoglycemia, what are the conditions that can result in hypoglycemia. Last day, Dr. Jacob has already discussed, but I'm just highlighting some and then moving on to the guidelines for monitoring of sugars in these cases. Very important, infant of diabetic mother and any other cases of hyperinsulinemia. Then SGA, that is short for gestational age, IUGR, intrauterine growth retardation, low birth weight and preterms. LGA, that is large for gestational age. Sick babies who are on ventilator, who is having respiratory distress, who are on IV fluids or TPN. Babies who are hypothermic or post-exchange. Babies who have infections and sepsis. Asphyxia, HIE, that is hypoxic ischemic encephalopathy. Maternal medications, which may be beta blockers, oral hypoglycemic agents, or dextrose infusions. Many syndromes are associated with hypoglycemia, especially Beckwith-Whitman syndrome. Also some endocrine abnormalities. Inborn errors of metabolism, especially disorders of carbohydrate metabolism, like glycogen storage disorders, disorders of glycogenolysis, fatty acid oxidation disorders, some amino acid disorders, and also mitochondrial disorders. Many of these may present with hypoglycemia as one of the manifestations. Also galactosemia, Medications, especially insulin, inadvertently, if it is given, or maybe for hyperglycemia, we may give insulin which may be overdosed or due to some other reasons. So all these conditions can result in neonatal hypoglycemia. So in high risk cases, that is whether it is infant of diabetic mother or an SGA or an LGA or babies with sepsis or ventilator, how will you monitor, and what are the guidelines for monitoring sugars in those at-risk neonates? All at-risk neonates and sick neonates should be monitored for blood glucose level. That's a dictum, and it has to be done. And term neonates who are healthy with no risk factors, there is no need. There is no guideline which says that all neonates have to be monitored for blood sugar. Now, how frequently and how should you monitor these blood sugar levels? The screening for blood sugar should start from 2 hours after birth, and the surveillance should continue 4th to 6th hourly. And how long should you how early should you continue? I've already mentioned 2 hours after birth. And how long? Till feeds are well established and glucose levels have normalized, which is generally by around 48 hours of life. And this monitoring has to be started even before 2 hours, especially if the mother is having starving or severe vomiting in such cases. And the maximum risk of hypoglycemia, as I already mentioned, is in the first 24 hours, but it may persist till 72 hours. Sorry. So I repeat, how will you monitor sugars for babies who are at risk? All at-risk neonates should be screened from 2 hours till the around 48 hours of life, when their feeds are well established and levels are normalized. And this has to be done 4th to 6th hourly, as simple as that. But though simple, and it has to be done regularly. Now, I would like to discuss some common nursing errors, as most of you, all of you are nurses, and it's a nursing training module. I would like to look into some common nursing errors which can happen, which many of these have happened in our NICUs also, which I've also come across, and many of us do come across. So let's look into that so that we don't make the same mistakes again. We learn from our mistakes. What are the problems? What are the errors that can happen during taking of samples? Especially in unstable babies who are hypothermic, who are having peripheral cyanosis. If you do blood sugar, you may get a false low value. So the periphery should be warmed well before you start doing capillary sampling. Then application of spirit or antiseptics before taking sample, or taking less quantity of without filling the circle, or more quantity of drops, all may result in wrong values, or sometimes it may not work at all. Very often it may be showing error of different sorts. Sometimes it may show some value which may not be the actual value. So these things should not happen. Then we know that most of the glucometer have codes, and the wrong code should not be used. So we have to double check that it is correct, and also we should double check if it is an expired or a proper glucose strip. If it is expired, we shouldn't use. Also, the storage of the glucose strips is important. It should be stored in the appropriate temperature that is mentioned by the manufacturer. And if you are taking a blood sample, suppose it's not a glucometer sample, taking a formal blood sample, if the blood sample is taken without the adequate preservatives, that is fluoride, or if it is transported late, the resulting values may be wrong. We know that fluoride inhibits enolase enzyme and thus inhibits glycolysis, which can happen if even after coming out of the body. So adequate fluoride, not too high, not too less, adequate, and should be transported to the lab immediately for evaluation. So let's remember that we don't commit these mistakes at all. Now, these were the errors during sampling. Now let's look on to some errors which can happen during treatment when we are actually treating a case. Delay in monitoring. Very often, checking blood sugar routinely is looked down upon as a simple thing, and very often an unnecessary thing by both the nurses as well as doctors as well as the patients. Very often they think what everything is fine, the baby is feeding well, what is the need for unnecessary poking. Especially when we may get busy, when we are looking into other sick patients, we may just may not follow the strict lines guidely or just increase the gap. Why 6 hours? Let's do once or twice a day. That is enough, we may think. And the problem is we may miss out a hypoglycemia. Then delay in starting treatment. We have not yet discussed the treatment. We'll be discussing, Dr. Rani Bashir will be discussing tomorrow the treatment and the problems associated with the treatment of hypoglycemia. So we will be learning that we have in symptomatic as well as in cases where the blood sugar value is too low, we have to start an IV line. And a delay in getting IV line, sometimes patients with shock, patients who are very sick, there may be delay, or procuring the IV fluid, sometimes the adequate GAR calculation, there may be some delay in the calculation, there may be delay in reconstituting the fluid and bringing all this. But we have to know that hypoglycemia is a medical emergency and it has to be done without delay. Get an IV line fast and start the fluid with adequate GAR. We know it's easy to say, but practically difficult. But we have to be ready and move as if it's an emergency. It's an emergency. Then not identifying extravasation. Very often this has happened in many places. We may be giving IV fluids at high GDR or high flow rate in order to combat hypoglycemia, but it would have extravasated. And it would be going on into the subcutaneous and outside the vein. Ultimately, the hand will swell up. At the same time, the sugar will go down. So it is very important and imperative to make sure that the IV lines are going well and they are not having any problems, and they always have 2 IV lines, so that if one is gone, immediately you get the next and you connect the line to the other one. Especially in cases of hypoglycemia, we should never be content with a single IV line. So that will solve the problem. Then infusion or syringe pump. The infusion pump or syringe pump, whichever we are using, has to be of a good quality, and it should deliver the infusion at the adequate prescribed range. If it's going too slow, it may cause unnecessary hypoglycemia. If it is too fast, it may cause hyperglycemia. Sometimes if it is empty, it may be showing no alarm. Nobody may know. So we have to observe when it is going, how fast is it going, is the pump working correctly, appropriately delivering, no adequately when it is empty, and immediately replace. The next should be already be kept ready, so that once this is over, you are replacing. And there should not be any delay in any of these things. Identifying problems with identifying complications. The management of symptomatic hypoglycemia as well as asymptomatic hypoglycemia are different. So the symptoms of hypoglycemia have to be identified, whether the child is the infant is lethargic, showing jitteriness or seizures. These activities have to be looked for and observed, and adequate management should be taken care at the earliest. So as I already told you, asymptomatic hypoglycemia, the cutoff is lower, while symptomatic, the cutoff is higher for IV infusion. All this we may be discussing tomorrow, so I'm not going into that today. So identifying the symptoms and signs of hypoglycemia as well as the complications of hypoglycemia in so-called asymptomatic babies is also important as it decides the management. So before we stop, I think we'll just go through and have a recap of all the things that we have already discussed, so that it remains in you, and you'll be able to revise now itself and learn it. So we are discussing only 3 or 4 topics. First of all, the symptoms and signs of hypoglycemia. Symptoms: lethargy, poor feeding, tremulousness, feeling cold, cessation of breathing, and many of cases are asymptomatic. Signs: hypotonia, jitteriness, seizures, cyanosis, and even cardiac failure. Complications: we have to identify the long-standing complications like motor delay, delayed developmental scales, lower IQ, as well as hearing abnormalities, and even seizure episodes. Pathology: typically it's in the parieto-occipital cortex. There are acute changes as well as chronic changes which may be evident in MRI. So we have to be very careful in dealing with hypoglycemia. Risk factors: infant of diabetic mother, SGA, IUGR, and LGA are most important risk factors. We should be looking. How will you monitor? Very easy to remember. All at risk have to start from 2 hours after birth and then continue 4th to 6th hourly till values are normalized. You may start events before 2 hours as per the situation, and may go on even after 48 hours as per the situation. Common nursing errors: errors during taking samples and errors during treatment. So hope all of you have understood something, and please go through the video again so that you can revise, and whatever doubts you are having, feel free to ask, feel free to share in the group. We are happy to discuss. We are happy to clear your doubts. All of us are there. Dr. Jacob, myself, as well as Dr. Rani will be there to help you and guide you. Also, many other senior faculty are there. And tomorrow we will be moving on to the proper treatment and all the problems associated with treatment of hypoglycemia, and also about mentioning about hyperglycemia and persistent hypoglycemia also will be covered in tomorrow's class. So I'm stopping today. Thank you.